it's actually really a pleasure to always speak to a crowd of predominantly clinicians and healthcare providers. And I assume probably everybody here but me actually sees patients, interacts with patients and treats patients. I mean, we see patients in my lab, but only, in terms of research. So this is really a pleasure to be able to interact with people who are actually at the front lines. So my talk is actually going to be in kind of two parts. I'm going to be talking kind of more basic science in the beginning. So if you're glazing over too much data, just hold on, because then I'm going to swing into in the second half another topic which might be more engaging for you, which has to do with my work involved in thinking about the neuroethics of using brain imaging to diagnose pain. Okay, so let's start with this. So actually, by show of hands, so who actually is a healthcare provider here that actually sees like everybody? Okay, and you're all in completely different areas. I guess many of you are physios, some are psychologists or psychiatrists, other types of healthcare providers. Whatever your specialty is, I'm sure you're all faced with maybe not this exact number of treatment options, but patients come to you and you probably still have to figure out what's the best way to treat that particular patient. Is that right? So is this what you do? I don't know if you can see that. It says, I want a detailed analysis, your best educated guess, and then round it out with some wild speculation, right? Yeah. But the longer you've been in practice, you actually have a great deal of experience, and probably your best educated guess is probably pretty good, because it's trial and error, and so that's pretty good. But can we do better than that? So my lab and many labs are now trying to come up with kind of biomarkers so that one day we will be able to have additional information that might guide these treatment decisions. And I'm going to talk a little bit about something I call the dynamic pain connectome, and hopefully some of these biomarkers, not just within the brain, but other sorts of biomarkers, will hopefully lead to us being able to generate kind of a report that says, what is the likelihood in that particular patient for a variety of different treatment options of having success. And so then, it might spit out and say, okay, for this particular person's brain and all their behavioral findings and everything we can measure, we think this person should go to CBT, for instance, and not have brain stimulation or something like that, right? So this is where we're trying to head. So what are the problems, and why do we need this kind of approach? And I'm going to be talking a lot about the drive towards understanding the individual patient. Okay, so the truth is we have a lot of things that can help some patients quite well, but many patients don't do well, and even the ones that do well sometimes have to stop whatever that treatment is because of some side effects. So why is that? Why is that the case? Well, one of the problems is the way that all sorts of approaches in medicine come about is because we try to acquire data, and we have this G2I problem, which stands for group to individual. So we do all this research, and drug companies do all these studies, and we look at the effects of surgery and all sorts of manipulations, and we spit out data that talks about on average what happens in a group, but you're making a decision on the patient that's in front of you, right? So there's a lot of potential treatments that probably got thrown out because it didn't show great efficacy at a group level. But in fact, it might have been very, very good for a minority of patients. So we have to rethink how we evaluate these treatments. And many people have been talking about this for many years. It's the classic case of lumping versus splitting.